Dear doctors, welcome to EasyMed. So this video is the second part of the series of the video pelvic infection. In the previous video we talked about the general defense mechanism of the genital tract and some other aspects of it. If you haven't watched that video, I would suggest that you watch the video, the first part, and then come back to this one. Today we will talk about pelvic inflammatory disease. Pelvic inflammatory disease. Which is also called in short PID. Now here I have a laparoscopic view of the internal organs, reproductive organs of a female. Here you can see. So what is pelvic inflammatory disease? Basically from the name you can get an idea that this is just inflammation of organs. This disease causes inflammation. Now you can see that here in this laparoscopic view you can see the condition the female is going through. It's very painful condition that she is going through. You can see here there is endometritis. There is endometritis here. You see the inflammation on the uterus. You look at the tubes are also very much inflamed, and no ovum at this stage can come from the ovary to the uterus through the tubes because it's very much inflamed. There might be some kind of hydrosalpinx as well, and even you see the position of the ovary. See, the ovary is also inflamed. It's not in proper contour. So the reproductive function is disturbed, and there is immense pain in such cases as well. And you can also find here, you see there is a accumulation of fluid in the Douglas pouch. So this is the if you remember from anatomy, this is the Douglas pouch. So you can see there is accumulation of fluid in the Douglas pouch as well, and there might be bacterial, there will be, not might be, but there will be bacterial infection in such cases as well. So it's a very painful and even deadly conditions in some cases. So how we may define this PID, how we may define this? We can define it as, this is a spectrum of infection and inflammation excuse me, spectrum of infection and inflammation of the upper genital tract, this thing, the upper genital tract, this is very important in the classification or in the definition. Typically involving what? It's typically involving the endometrium, the tubes, the fallopian tubes, the ovaries, peritoneum, and at times pelvis, peritoneum or pelvis, and parametrium as well. What you should remember here is that in the classification of PID, we never consider cervicitis. cervicitis. We never consider it. This is not a PID. Now, talking about the epidemiology of the disease. Epidemiology of the disease, 1 to 2% of young females are affected, and these young females are in most cases less than 25 years of age. Now, what are the risk factors? The risk factors. Risk factors of PID. Firstly, multiple sex partners, no usage or lack of usage of OCP, a history of PID, some of the IUD users, intrauterine device users, but not LNG IUDs. It is also found in low socio-economic groups, and naturally it will be found in women having sex partners with STI, sexually transmitted infections, and at the end but not the least, genetic predisposition. Now, so we have learned about the risk factors. Now, what are the protective factors against PID? So, protective factors. Now, protective factors, we can group it broadly into two. One is contraceptive, another is, let's take it like other factors. So in contraceptives, what contraceptive methods are there? We have the barrier method of contraception, that is condom, diaphragm, plus spermicides. Use of OSCPs, steroids, some natural things which are actually protective against it, that is the thick mucus. We also call this spin barcade. You can find about this, I have talked about this already in the previous session. And less duration of menses. And naturally, monogamy is one of the methods. In others we have pregnancy, naturally, because in pregnancy what happens, we have closing of the internal os, so naturally the gate is closed basically, and apart from that there is too much level of estrogen and all these, so which are natural protective factors against these kind of infections. Please go to last video for it as well. Menopause. Some vaccines like vaccines against hepatitis B, HPV vaccine or human papillomavirus vaccine, and a very healthy habit is postcoital washing of the genitalia. Next, we will talk about the modes of affection. Modes of affection. So it might be gonococcus. This mainly happens it happens in the tubes through mucus, and this is facilitated by sperm. Very intricate point I'm telling. Sperm, and as well as by trichomonas. Apart from this, reflux of blood into the tubes. With gonococci. So reflux of blood may happen in many instances, and if that blood is infected with gonococci, it can reach to the tubes. Then mycoplasma. Let's make it more definite. Mycoplasma hominis. This is mainly found across parametrium. And some secondary organisms are there, and this happens through lymphatics. Now let's discuss the pathology. Primarily in endosalpinx. We find firstly there is cilia microvilli destruction. So there is cilia microvilli destruction and epithelium destruction as well, epithelial destruction as well. Then there is acute inflammation in all layers of the tube. There is acute inflammation in all layers of the tube. Acute inflammation in all layers of the tube. There is now, because of this inflammation, this acute inflammation in all layers of the tube, you can find exudates exudates, which actually pour into the lumen of the tube and agglutinate the mucosal fold. And we can find here edema and hyperemia as well. If you remember about the exudates, I have shown you in the laparoscopic view how there is accumulation of the fluid in the Douglas pouch here. Let's continue. Apart from this, the abdominal ostium is closed. How it is closed? This is closed by this edema. This is closed by this edema. So you see the pathology, how well knit it is, one after another. Then the exudate flows through the abdominal ostium. This exudate, let's take it like this. This exudate flows into abdominal ostium. Then through abdominal ostium, what it causes? It causes pelvic peritonitis. And or pelvic abscess. Or it may affect the ovary as well. Basically, the fluid goes out through the abdominal ostium, and the nearby organs it can affect the nearby organs. What we have nearby there? Just imagine the structure. We have the pelvis, so there might be pelvic peritonitis, there might be abscess, and it may affect the ovary as well. Now, how is this exudate? The exudate first, the exudate, actually there is two types of exudates are found. One is watery exudate. This is found in hydrosalpinx. I have previously said about hydrosalpinx. And there might be purulent exudate, and this is found in, or this causes pyosalpinx. If you have been into any OT, you have seen any laparoscopic resection of the tubes, tubectomy and oophorectomy, I think you have seen already all these cases. Then clinical symptoms. Let's come to clinical symptoms. What symptoms will the patient have? Clinical symptoms. The patient will complain you about a bilateral lower abdominal pain. She will complain you about a bilateral lower abdominal pain. This pain might be 3 days. The patient might say you that dear doctor, I am having this pain for 3 days. So if she says 3 days, you might suspect directly a gonococci infection, gonococci. And if she complains that it is almost around 5 to 7 days, 5 to 7 days, then you might suspect a chlamydial infection, chlamydia. Apart from this, so this is the primary complaint. Apart from this, there will be fever, there will be headache, lassitude, irregular and excessive bleeding. This is often found, irregular and excessive bleeding. And apart from that, there might be some foul vaginal discharge, there might be dyspareunia, so this dyspareunia is basically pain at the time of coitus. And pain, nausea, vomit, these things might be there. Now, very importantly, this is a very intricate point I am telling. If there is pain and discomfort in the right hypochondria, if there is pain and discomfort in the pain and discomfort in right hypochondria, then this is a case of perihepatitis concomitant, perihepatitis concomitant, and this is seen in 3 to 10% of all the cases. And apart from that, another very important point is there might be this perihepatitis concomitant if it's caused when there is a vascular dissemination of infection or due to transperitoneal flowing, and this is also called this perihepatitis concomitant in PID. This is also termed as Fitzhugh-Curtis syndrome. Fitzhugh-Curtis syndrome multiple times has been asked in many exams. Now we go for investigation. What are the investigations of choice? Investigation. The first investigation of choice is D and C, that is dilatation and curettage. Dilatation and curettage. This is done for identification of organism. Identify organism, the causative organism. In here, basically what you do, you take this dilator, vaginal dilator, you dilate it and collect the discharge. You collect the discharge in a collecting in a collecting base. So you collect the discharge, collect discharge. You can collect this sample, this discharge, and you send this for pathology. You send this for pathology. And this discharge, you might take it, you might collect it from Bartholini gland. You might take it from Bartholini gland. You might take it from cervical canal, and you might also take pus from the tubes. Now you should give the patient always, as this is a case of infection, so you should be very particular with the hematological parameters of the patient. So blood testing, what you should do in the blood testing: CBC, very importantly, CBC, complete blood count, and you should check for leukocytes. There is often, in most of the cases, there is leukocytosis, that is, leukocytes are high, around 10,000 per millimeter cube. Leukocytes are high, that is, leukocytosis is found. You should check for ESR. Okay, ESR is also found high. Minimum it is found that minimum it is 15 millimeter per hour. Then you should go for laparoscopy. And this is, let's write it in yellow. This is the gold standard. Ultrasonography is done. Why you should do this ultrasonography? To find if there is any fluid accumulation, if there is any fluid accumulation in the Douglas pouch, for fluid in Douglas, or you should check for adnexa. And caldocentesis, which is actually peritoneal fluid aspiration. And in the peritoneal fluid aspiration, if there is PID, you will find that the WBC count is around or greater than 30,000 per ml. Let's talk about the differential diagnosis of PID. So when a patient comes to you in your gyno clinic or department, the complaints in differential, so you have to do differential diagnosis. Bilateral pains and all these complaints are similar with many other diseases, many other clinical conditions as well. So what are the differential diagnosis, diff diagnosis of PID or pelvic inflammatory disease? Appendicitis, most importantly, because bilateral flank pain is very common in appendicitis. You should always be particular about. Then ectopic pregnancy, ovarian torsion, endometritis, diverticulitis, And last but not the least, UTI, urinary tract infection. And please remember, urinary tract infection in severe cases also shows flank pains. The patient will generally complain about pain in UTI as well. And complication of this disease, it's from basic and general sense, you can say it is peritonitis and septicemia. Peritonitis and septicemia. Then we come to therapy. How will we treat this patient? Therapy. So therapy is done basically in an outpatient and inpatient basis. Outpatient. So first let's discuss the outpatient therapy. There will be 48 hours monitoring. Monitor the patient for 48 hours. If there is response, send the patient home. Nothing. If there is no response, this might be anything. This might be pregnancy, this might be HIV, this might be abscess as well, this might be ectopic pregnancy as well. So if there is no response in 48 hours, what we do is we send the patient to inpatient. We send the patient to inpatient for inpatient therapy. And what is inpatient therapy? This is hospitalization. For the purpose of what? For the purpose of IV fluid and antibiotic, mainly antibiotic administration. Now let's discuss what is the outpatient therapy. What is the guideline of doing the outpatient therapy? Guidelines as per the CDC 2015. As per CDC 2015, ceftriaxone 250 mg intramuscular, 1 dose, or cefoxitin 2 gram intramuscular, 1 dose, plus probenecid acid 1 gram PO, 1 dose, or cefotaxime injection IV. So either you should go for ceftriaxone 250, or you can go for cefoxitin and probenecid acid, or you can go for cefotaxime. Along with this, second regime is you have to give the patient doxycycline 100 mg PO for plus minus 14 days. Generally doctors prefer that 7+7 regime. If the patient is cured in 7 days, we don't go for another 7-day regime. And metronidazole, (500 mg). Same thing, PO plus minus 14 days. See, you can remember this by remembering 3C. and DM. 3C DM. You give any C from all the 3 C's, that is ceftriaxone, cefoxitin or cefotaxime, plus you have to administer DM. DM is doxycycline and metronidazole. Now let's come to the inpatient therapy. The inpatient therapy guidelines, this is also as per CDC 2015. So what are the inpatient guidelines? I would rather write it little down. So the inpatient guidelines, we can divide it into like this 3 groups: group A, B and C. Cefoxitin 2 gram intravenous every 6 hours for 7 days, plus doxycycline 100 mg, PO, BID 14 days. The next option is, this is A. B is clindamycin 900 mg intravenous. You see, yeah, IV everything is intravenous, nothing is oral, 8 hours apart from the tablet regime. Okay, main thing is intravenous, plus gentamicin. Two milligram per kg intravenous. This is the loading dose. And continuation dose is 1.5 milligram per kg IV every 8 hours. And aztreonam is also prescribed. That is 2 gram IV slowly. And C is, it is basically alternative. This is ampicillin, sulbactam, 3 gram intravenous every 6 hours for 3.5, that is around 3 to 4 days. Plus doxycycline 100 mg, PO, BID is again 14 days. So here we have discussed completely about all the main things of pelvic inflammatory disease or the PID. We have seen the laparoscopic view of it. We have discussed the epidemiology, the etiology, and the differential diagnosis, the symptoms, and the therapy as well. In the next session, or the next part of this video, we will discuss some specific incidences of pelvic inflammatory diseases, like pelvic inflammatory disease after pregnancy or after some gynecological procedure. We will discuss it in the next video. If you like the channel, please do contribute and support us by liking this video, sharing it amongst your fellow doctors and medicos. Subscribe to the channel and don't forget to press the bell icon. Please do like this video, comment on it, share it amongst your friends, and don't forget to subscribe to our channel and press the bell icon.